We're going to get started. Welcome, everyone. My name is Guillaume Fontaine. I'm an assistant professor at McGill University, and it's my pleasure to be hosting this session of the Global Leaders in Implementation Science series. Today, we're welcoming someone from Columbia University, so Dr. Rachel Shelton, Professor of Sociomedical Sciences, a social and behavioral scientist, with expertise in training and dissemination and implementation science, community-based participatory research as well. She has over 15 years experience in conducting and leading qualitative and mixed methods research in different clinical and community settings, focusing on cancer and other chronic diseases, a large number of peer-reviewed publications, so really an extensive academic record. She's also currently the co-director for Translational and Implementation Science at the Irving Institute for Clinical and Translational Research at Columbia University. She's also director for the Implementation Science Initiative through the CTSA and helps lead research and capacity building efforts in implementation science across the university. She has over 15 years experience being a study principal investigator on different grants funded through the American Cancer Society, the NCI, NIA, and other institutes. She's also involved in the Society of Behavioral Medicine in leadership positions and associate editor of the Annual Review of Public Health. So please join me in welcoming Dr. Rachel Shelton with community engagement to promote sustainability of evidence-based interventions. If you have any questions throughout the talk, please use the Q&A section, and we're going to go through the questions at the end of the session. So Rachel, Dr. Shelton, the stage is yours.
Thank you so much, and thank you for having me. I'm honored to be here. So I am going to jump right in. Thank you for that introduction. Okay, so I'm going to talk today and provide kind of an introduction to sustainability in the field of implementation science. That has really been the passion and focus of my work in implementation science in the past 15 or 16 years. But today I'm going to take a slightly different angle, and I'm really going to think about how does community engagement intersect with our ability to be able to promote the sustainability of evidence-based interventions. And I'm going to give some examples from my own community engaged work and partnerships in the last 16 years that have focused on sustainability of lay health advisor interventions in particular. And as I'm going through this, I'm going to think about and share with you some of the findings about sustainability, but I also want to highlight how we were approaching community engagement in our research process as well, and how that really enhanced the relevance of the research and the research partnership and has enabled us to have that partnership for so long. So I'm really going to think about community engagement from multiple perspectives in sharing this work. And then I'll highlight some future directions and opportunities in the field related to this intersection of community engagement and sustainability. A little bit about me and where I come from and my background. So my, 20 plus years ago when I was getting my Master's of Public Health, I was really trained in community-based participatory research, CBPR. And that's kind of the foundation of a lot of my work, and that was my initial training. I got my doctorate studying social epidemiology and focused a lot on understanding social factors that impacted cancer disparities and cancer screening. But as I started my faculty position around 2010, I was doing all the right things. I was publishing, I was, starting to get some small grants, but I felt like my work was having not as much impact as I wanted in a lot of the community settings where I was partnering. So I really came to the field of implementation science, and I'll talk about sustainability in particular, because I saw implementation science as really having the potential to translate back to the community to have impact. So that's kind of what brought me to the field in particular. So when I talk about this work, just so you know, this is kind of the intersection of where I come from in terms of CBPR, health disparities and social epidemiology training, and now implementation science. Okay. So again, many of you, may have done work in implementation science, or you may be newer to this field. But as you may know, a lot of the work in implementation science has focused on the implementation phase, right? How do we get things into practice in clinical or community or public health settings? And when you look at what's been funded, a lot of that really focuses on that first year, right? What happens in that initial implementation phase. There was an analysis done in the United States of how much sustainability research has actually been funded that focuses on what happens a year later, or 2 years, or 5 years later. And they found that only 3% of research studies have focused on that longer term sustainability phase. So it's been a huge gap in the field. So where does sustainability fit within implementation science? So if we think about kind of our traditional translational pipeline, we often start with our efficacy and effectiveness studies to establish what programs and practices and treatments work. And then often our implementation phase follows from that, and we think about how do we get this now into real world practice. But as you can see there, sustainment is kind of tucked in there as that very last phase. And that's what often happens. Even with the best intentions, we rarely get to it. It's often kind of an afterthought or a tag on. And as a result, it's not really a surprise that we really struggle to sustain evidence-based interventions in real-world settings. So we have tried to make the case in our work that we can't wait to the end to think about sustainment or sustainability, that we need to think about it early and often along this translational continuum, and that it really requires that we are engaging with the communities, the implementers, and the real world settings where we ultimately want to implement and sustain. So we have to be thinking about engagement and community engagement early and often along this translational science continuum if we want to be able to sustain. We've also made the case that if we want to have impact with our implementation science, lasting impact, and actually create systems change, transformational systems change, we can't be implementing and then having the programs kind of erode or not be continued. So sustainability, in my eyes, is also essential for us in being able to create lasting population health impact. So for those of you who, this area might be newer, why do we care about sustainability? So we know from the science and the literature that no matter the intervention, setting, population we're working with, sustainability is a common challenge. Only about half of evidence interventions are sustained beyond 1 year. And there's been several kind of empirical studies and reviews that have substantiated that. So it's a challenge. And increasingly, I think from funders and from the public and from partners, we hear, we have all this investment we make in that initial development and testing of the evidence-based intervention or practice, and maybe its initial implementation. But there's real frustration and wariness to continue to partner if those interventions aren't maintained over time. So, this has implications for, resources, time, the investment that goes into all of that work, and frustration often among those community partners or those clinical or public health settings we're partnering with when the interventions aren't continued. So I think it's an issue as well in terms of accountability of our research investment. But we know it is also a challenging issue both to research and a challenging thing to actually do to sustain evidence-based interventions. Just so we're all on the same page too in terms of definition, I love this definition by Julia Moore and Sharon Strauss and colleagues of sustainability, this idea that after a period of time, and it's often a year or more, the program and the strategies continue to be delivered, the behavior change is maintained, but this recognition that that there is dynamic context, that the intervention and strategies may need to evolve over time to adapt to changing systems, changing context, changing population needs, and also changing science, right? Our guidelines often change, our evidence also changes. So increasingly, there's a recognition that sustainability or sustainment is not this static end goal that we're trying to reach and that we'll get there and then we'll check it off our list, but it's dynamic, right? And I think that is why it involves kind of ongoing assessment of context and ongoing engagement with our partners and in our implementation settings. Okay. So in making the case, again, that we can't wait till the end to think about sustainability, we really have made the case that we need to design and actively understand and plan for sustainability from the outset. And again, connecting the dots early, not hoping that we'll be able to sustain when we get there at the end, but really thinking intentionally about the selection of our evidence-based intervention or its refinement up front in terms of, is this something that could be implemented and sustained? How complex and costly is it? How does it fit? And how could it be integrated? What is the cost in terms of its support? So really understanding from the start its capacity for sustainability. And increasingly, there's a literature, an empirical literature, that has also started to identify a lot of the contextual factors that matter for sustainability. And a lot of these, again, relate to community engagement and partnership. We know that in the outer context, external partnerships and supportive funders or supportive resources or partners to support resources for implementation is one of the strongest factors that predicts sustainability. We know that having champions, right, those relationships with champions, whether they're internal or external, is critical to sustainability. And we know the extent to which we understand and address community needs with an evidence-based intervention is also essential to sustainability. So a lot of the factors that matter for sustainability relate to our ability to engage and understand community needs and context. There's been a really nice review too that Juliet Iwalamor did in Sub-Saharan Africa of evidence-based interventions related to HIV prevention. And in this review, they found the single most important factor that predicted whether or not evidence-based interventions were sustained in Sub-Saharan Africa was the extent to which community members and community leaders were actively engaged in selecting what the evidence-based intervention was and were given ownership in adapting it. So again, we know that early phase in terms of selection, engagement, involvement is critical to later sustainability. Okay, so that's a little bit about sustainability, why we care about it, and how it might relate to community engagement. And next, I want to talk a little bit about what do we mean by community engagement? And again, why might it be essential in laying the foundation for later sustainment? So, there's lots of different language that is used in this field. Some people talk about community engagement, some people talk about co-creation, some people talk about participatory approaches. And I think that kind of language is increasingly common in implementation science. But no matter the language we're using, the meaning behind it is, it's not a research method, it's really an orientation or approach to the research, where there's engagement of all partners throughout the research process. And the idea is that this engagement can help improve the quality and the relevance of research to end users. And often there's a commitment to action. It's not just about documenting what's going on or describing or producing research, but there's action, a commitment to action as part of the research process and translation. Often there's also a commitment to sustainability, right? That this is not a one-time partnership and then it's not a helicopter research kind of approach where the researchers come in and then leave once they get the data. So there's a commitment to sustained partnership. And often there's a focus on strengths and assets. So really understanding the resources and strengths that the community already has that can really be further elevated and supported through additional capacity building on the ground. And often people think about this as really a continuum. Here, if we think about varying levels of power and control in research, responsibility and ownership, participation and influence, it's not one size fits all in terms of what this might look like. And some research might be more investigator driven and involve community advisory boards, whereas community-driven research would really be on the other side of things, where the community is really in charge of the resources and decision making. And often we see it somewhere along this continuum, depending on the nature of the mechanism for research or the interest even of community members to be involved. So again, often this exists on a continuum. Shobha Ramanathan at Harvard School of Public Health has done some really nice work in this area, so I've highlighted a couple of her papers. And again, she talks about different roles that the community might play, particularly in implementation science in research projects. So it might be consultative, right? So when there's targeted expertise, maybe to understand the lived experience of a community to inform implementation efforts. There's collaborative, where academics might lead the research study, maybe they obtain the resources for funding, but there might be deeper engagement of community members in planning and selecting the evidence-based intervention. So again, thinking about this along a continuum, I think helps us think about this as not one size fits all, and this may look different, again, based on the needs and resources of the community and the research partner. So this is a nice model and I think nice language for us to think about in approaching the different continuums of community engagement. Shobha has also written about how there's value in community engagement, especially in implementation science, all along the continuum of the research process. So if we think about everything from selecting our evidence-based intervention, right? That we're not in our office as academics with the door closed on the computer, in PubMed, selecting which evidence-based intervention is a fit, but we're actually engaging the community members or the community implementers in the settings where it's going to be implemented because they have the insights into what would work and be feasible, right? In terms of study execution, everything from recruitment to retention to tailoring the evidence-based intervention. And again, because often those community members have the networks to be able to support that and the trust, and they're often the credible messengers in those settings. They can provide insight into understanding and interpreting for data analysis, right? If there are findings, qualitative findings that need kind of unpacking and understanding, there can be important insights provided by community there to make sure we're understanding context accurately. And in dissemination, again, with those networks, right? There might be trusted sources of information for dissemination that we're not aware of or don't have access to as academics. And then finally, I think there's increasingly a move away from implementation efforts that are one time and short time where researchers come in and then leave. So I think increasingly when we're engaging community partners, we have more insight into building implementation strategies that might build more local capacity and might have more promise for sustained change. So again, these are some of the benefits that community engagement and implementation science can bring in particular. Again, when we think about community engagement and participatory science and implementation science, I think it's a lot of the same principles we think about for CBPR. But I think sometimes what can be different in implementation science is our context and the settings in which we're implementing in our community might be very multi-leveled in terms of who we're engaging, right? So often in a CBPR study, your main end user might be the community members, and that might be who you're engaging with. But often in implementation science studies, it might be both the community, the leaders within a community-based organization. It could be the implementers, the lay health advisors or the community health workers or the community-based primary care practitioners or providers. And it might also be the patients, the community members, and the families. So often when we think about community and implementation science, it might be really multi-layered in terms of who those stakeholders are. So I think that's important to think about. And I think similarly, a lot of the same principles for community engagement more broadly apply here, right? Everything from, community engagement helping improve the relevance, feasibility, and acceptability of our solutions and strategies that we select. Again, there's a lot of the same commitment to action and capacity building as part of the research. Again, there's a big focus on building trust and focusing on being strengths and assets based. And there's a real value, I think, in understanding context and implementation science, but here also understanding community and social context and lived experience and how that might impact implementation efforts. So again, these are some really nice resources here that I've put from Dr. Ramanathan and others who have really delved into what this can look like specifically in the context of implementation science. And we have also written a chapter in the handbook of community engagement principles. A new edition of it just came out last year. And we wrote the chapter on application of community engagement and implementation science. So this is also a nice handbook that has both kind of guidance, both for academics, but also for community partners who are looking to partner around an implementation effort. Everything from, initially building that initial partnership and planning for implementation, to examining, what the community partners' experience might be with prior implementation efforts or with the university or setting in which you're partnering, to working with partners to examine the evidence base and really ensure both contextual and cultural appropriateness, to identifying ways to build capacity for implementation in the local community setting. And something we don't always think about, even in our research efforts, that we're actually identifying metrics and outcomes that are meaningful to community partners. So again, we provide some guidance and insight into what this can look like in the context of implementation efforts. And happy to share that if you're not able to access it online. Okay, so that's some background in terms of both the principles of sustainability and implementation science and the principles of community engagement and how they intersect. So next, I want to kind of take you down a little bit of a journey of my research on sustainability in the last 16 years and kind of talk you through a little bit both about our findings, but also about, again, how we have approached community engagement more practically in the context of our research. So again, I came to implementation science around 2010, 2009, 2010, when I was feeling frustrated by this kind of lack of impact of what I perceived as my own work, its lack of translation in the community. So I had a mentor, who had already been involved with this amazing nationally disseminated program that had been developed by and for Black women, Black cancer survivors, and lay health advisors. So it already was an evidence-based program that had been in place 20 years. But it was really having challenges in being sustained. So she said, there might be some nice opportunities here to build a partnership with an intervention that's already, gone through the process of community engagement, is really focused on addressing cancer disparities, but has a really important gap in terms of implementation and sustainability. So we partnered, and they really brought me to implementation science because they had an identified need. And I really came to the field to try and understand how could we sustain this program. So again, that's really what brought me to the field. And we have really, over the past 16 years, focused our work on trying to answer this question, both funded and unfunded. But I'm really grateful to them for this partnership. So what does this look like and what is this program? So again, we know all programs have challenges in sustaining. And I actually think this program is an exemplar. At this point, it was developed in the early 90s. And in some cases across the country, it has been sustained for 30 years. So it's really actually an exemplar in many ways, despite the challenges that it faces with sustainability. So again, this program was developed by and for Black women, and it's really based on community need in terms of addressing some of the stigma and discrimination and challenges that women face in accessing breast and cervical cancer screening. It's strengths-based, it addresses a lot of social challenges, and it's delivered by women from the community. There's a very powerful part of these community-based programs where the lay health advisors and cancer survivors tell their story. They provide these testimonials of how they were able to access care and navigate the system. So again, it really has that trust built in of the community because women come from the community. And most of the sites across the country are truly community-based. So again, this program has had a huge impact. It's been identified as one of the National Cancer Institute's evidence-based programs, nationally disseminated, reaches over 15,000 women a year. So again, I think that part of the reason this program has been so successful in terms of being sustained is that the foundation of it was built through community engagement, and that has, I think, really served it well in terms of being able to address and understand local community needs. So when we got together, I guess 2009, 2010, we really wrote this grant to try and answer the questions that mattered to them. So we put in our first grant together, a 2 or 3 year grant to the National Cancer Institute, and they really drove the questions in terms of helping us think through what they wanted to understand. So we wanted to look at what the characteristics and capacity were of lay health advisors and role models who are in this program, what brings them to it. What capacity do they build in their communities? What factors impact whether or not these women stay in the program? So there was a lot of attrition and turnover, which we know really impacts sustainability. And what factors impacted the sustainability of the program from their perception, from the perception of the lay health advisors and also the project directors at the sites. So we were at 8 sites across the country, and we had 76 lay health advisors who participated. So this was our first study that we published together. Here you can see these are all the sites across the country, and then we had 8 of them participate. So you can see we had some nice representation across the country. So again, our first step, and this took me many, many years, was just to get to know the sites and to build the trust, right? I was an outsider who had gotten this grant, but that it really, really required that I was on the ground in these community sites. So I spent much of my time during this funded grant at the sites, getting to know the sites, collecting the data, and really building that trust. And again, making sure that we were answering the questions that mattered to them. So, you know, here in this first part, we really documented the capacity that this program brought both to the community, the broader community, the organizations in which they were embedded, and how it built capacity for women, for cancer survivors in particular, to be able to help navigate health in their communities. So that was the first piece. We did some qualitative work to understand what brought women to these programs, you know, in terms of giving back to their community, and what kept them in the programs over time. Some women had been lay health advisors for 16 years. So some of them were very embedded in these programs. And we learned that a lot of them came to these programs and in these roles as implementers to give back to their communities, but many stayed because of the social networks and the communities that they developed and the sense of empowerment that they developed in these roles. So as part of this, we really wanted to document the community, individual, social, and community capacity that was built through these lay health advisor programs and really document that for them. Because we really felt like these programs, the impact they were having in public health were undervalued, and that this also had huge implications for their ability to sustain the program. So we documented this, and then we looked at, okay, we've documented all this individual, social, and organizational capacity and all the factors that they say really matter for sustainability. But what factors actually end up predicting whether or not the women stay in the program and or drop out? So we followed 76 lay health advisors and role models who were implementers in the program over 2 to 3 years. And we found that about a third of them were inactive or dropped out of the program over time. And so we wanted to look at, was it these individual level factors that predicted their dropout? Was it the social factors in terms of the networks and support? Or was it the role related factors, right? The benefits or the challenges they experienced in the role, the extent to which they were supported financially through the role, the self-efficacy in the role. And what we found was that all these factors mattered, but a lot of these factors in terms of the social benefits they got and the individual benefits didn't vary. They all reported very high levels of social and individual benefits. But where we saw the variability was at the organizational level in terms of their embeddedness within organizations. And we found that organizational factors really predicted whether or not lay health advisors stayed in these roles over time. And we found that community partnerships, the extent to which these programs have and trusted partnerships with community centers or academic centers was the strongest predictor of whether or not these women, these lay health advisors remained in the program and the programs were sustained. And we did a little qualitative research to understand what was happening there. And we found that often when there were these partnerships, there were these academic champions, these trusted champions who were able to access resources and help cover some of those financial gaps when the programs were struggling. So everything from offering space to giving printers to helping support stipends for lay health advisors. So again, those partnerships and that community engagement and that partnership was critical to sustainability. We then did some qualitative research to further unpack those quantitative findings. We wanted to look a little bit more at why and how those partnerships were being built and learn a little bit more from the lived experience of the project directors and the lay health advisors in terms of their perceptions of sustainability. So again, we went more in depth. I won't go through all of this, but again, we learned a little bit more about those partnerships and resources, how they exchanged money and space through these partnerships. We learned about how the critical role that the program director played in these sites and their ability to communicate and support staff as being essential to the sustainability of the program. We learned again about the motivation and experience of the lay health advisors in terms of their social networks and their engagement across the site, especially for the cancer survivors. We found that many of them in these positions often had recurrences while they were lay health advisors in this program, but this network really gave them a sense of value and a sense of strength as they were overcoming this. So again, the value of the cancer survivors in particular having this network within the community. So what we did is we found all that quantitative data about what mattered for attrition and sustainability. We took all that qualitative data, we laid it out, and we worked with the board and the sites to really identify and create a conceptual model for sustainability that was driven by everything we had learned from them. Again, everything we learned about with the partnerships and the funding and the community support at the outer context level, everything we learned about with the champions and the resources and the intercontextual level, and everything we learned about the intervention and the implementers that mattered to them. So we created this framework we called the Lay Health Advisor Sustainability Framework, and we published it together in 2017. And then, we heard a lot of feedback from them and others saying, okay, not all these factors can matter for sustainability. Which are the ones we really need to focus on? Which are the ones that actually predict whether or not our programs and sites are sustained over time? So we applied for a grant from the American Cancer Society and received a grant to allow us to study across the country, across all 16 sites, and actually test this model, test which of these factors actually ended up predicting across 5 years the sustainability of the program. So we just finished that study a couple of years ago. Again, we had 16 sites across the country, 201 participants. And again, those participants are the implementers. They're the lay health advisors, they're the cancer survivors, and the project directors. Here you can see the lay health advisors and the project directors weighed in on what was feasible, but also what was meaningful to collect in terms of sustainment outcomes. Ideally, we would have been there at the sites able to collect all this data, but we ended up only being able to do self-report data in terms of number of programs delivered, the extent to which lay health advisors continue and are sustained in the program, and the number of women they reach and screen in the community. So we had lots of indicators that they felt were both feasible and meaningful to look at. We did a comparative case study. So at this point, many of the sites had been involved with our research for 8 to 10 years. So we were able to categorize sites into higher sustained sites, moderately sustained sites, and lower sustained sites. And we looked at differences from our qualitative and our quantitative findings in terms of what were some of the characteristics from our framework that predicted and mattered for sustainability. And the lay health advisors, all this qualitative data was critical to really unpack and really name specifically what was happening with respect to these factors that we had named in the conceptual model. And what we found again was that the community partnerships were really what were driving the ability to sustain, and the partnerships and relationships and support from external funders and healthcare centers and cancer centers. So again, those partnerships were really the strongest predictors of whether or not they sustained. And we found that was what ultimately impacted their ability to have champions and their ability to have funding. So again, we learned that sustained community and academic partners and champions are critical to sustainability. We also learned that it was critical that sites were engaging actively with their communities to understand needs over time. During COVID, as you might imagine, sustainability was even more challenging. And that became the case for all the sites. And a lot of the programs had to put breast and cervical cancer screening kind of on hold while they addressed a lot of the social needs, everything from housing insecurity to food insecurity, because they said if we're not addressing these community needs, we're not able to get to addressing the health needs. So again, a lot of the sites that were able to sustain during that program adapted to community needs to be able to maintain their funding and maintain their programming and maintain their impact. One thing that we did was really, really critical, and I think was probably most critical in terms of our ability to continue to partner with this group, was we collected a lot of data from them on what their capacity was for sustainability using the program sustainability assessment tool, the PSAT, which is an online measure. And what we did is for all the sites, for all the programs, we gave all their data back on a yearly basis. So everything we collected from all the sites, lay health advisors and leadership, we gave back to them so that they could track for themselves what their needs were in terms of funding, in terms of their partnerships. And they were able to apply even for external funding on their own to address some of those needs. So again, this is just an example of some of the visuals we used as we helped them identify areas where they felt like they were strong and doing well, for example, in terms of program adaptation, and areas where they felt like they needed further support and guidance and external support in terms of funding and strategic planning. So giving that data back has been really an essential part of our research partnership and has also, I think, contributed to their ability to sustain the program. Okay, so we got to the end of that phase. We had done our 5-year study. We had found and learned a lot about what mattered for sustainability in terms of those community partnerships. And then, our community partners said, okay, we've learned a lot, we've partnered a lot, but what are we doing with this data? How are we now taking action to actually sustain the programs? So we said to them, we want to learn from you. What do you think are the strategies and interventions that would help you actually address some of these challenges to sustainability? So all of the sites, the leadership, the lay health advisors weighed in and ranked what they thought would be both effective and feasible strategies for sustainability. And we based our next grant on that, on testing strategies that they directly identified as being actionable, feasible, and effective. So everything from creating communities of practice to exchange lessons learned on sustainability, to receiving training now on a business and entrepreneurship program that really seeks to target and help them build the business case for their models and think about how to commercialize that. So we now are in the phase of testing strategies to support sustainability of the program. And again, everything that we have developed, everything we have created in terms of the strategies and their content have been informed by the sites. So we are excited. We're right in the middle of this and hope to have some findings to share down the road about what we learned. Okay, so that's a lot about sustainability and our community partnerships. I want to highlight one additional area that really emerged related to sustainability, but was really a community concern that was elevated and that we ended up really trying to unpack more as a result of the feedback we heard from community partners. So often we talk about implementation and sustainability, but another critical area is how do we remove or discontinue program components or evidence that is no longer evidence-based or might be costly. And in the case of the programs that I've been speaking about for the lay health advisor programs for breast and cervical cancer screening, the evidence base has changed over the past 20 to 30 years since the program has been originally developed. So the programs were really struggling with, what is the actual evidence base and what's the evidence base in particular for Black women who have more aggressive tumors at younger ages. And so we did some work to understand, are the programs staying evidence-based? Are they adapting to a lot of the new guidelines that are out there in terms of which types of screening to get, how, at what ages and how often? And what we found is that, all the programs knew about the new guidelines. They knew what should be happening in terms of mammography screening, from the U.S. Preventive Service Task Force, but they did not trust the guidelines. They said the guidelines were developed by and for European and white women, and they don't reflect higher risk populations. So they really felt strongly about keeping screening guidelines where they were able to screen at younger ages and more regularly. And they made the case with their funders that for Black women that this was important. And we learned a lot from them in terms of why they didn't trust the guidelines and why they didn't feel like it was relevant for them, right? They talk about, again, how Black women often are diagnosed at younger ages, how the cancer screening guidelines are always changing. And this is true. They have actually even changed since the time that we have published this work. And so there was this notion that if we keep changing the guidelines and we're switching it every couple of years, that women are not going to trust us as, credible, trusted messengers in the community. And then there was really, again, this belief that the guidelines didn't reflect their lived experience in terms of having more aggressive cancers at younger ages. So again, I think we have to think about when we're trying to de-implement or implement, how trusted is the evidence in the community? Do the guidelines or does the evidence-based intervention reflect the needs and experiences of the population? And I think we have to really weigh the pros and cons of thinking through what's being implemented or what's being de-implemented and who gets to decide that. And so we had the opportunity, the lead community partner, Dee Johnson, and I had the opportunity to present some of this work and some of the issues around trust and mistrust of guidelines at the National Academies of Medicine. And most recently, the screening guidelines have actually changed to be consistent with younger age and more regular intervals for Black women, which is consistent with how they had originally kept it. So again, I think some important considerations as we think about this intersection of community engagement and evidence. Okay. As I wind down in the next 5 minutes, I want to make a few more key points about big picture as we think about this intersection of community engagement and partnership. So I think as you heard from the findings and through our partnership, a lot of what we have learned about, I think, goes back to principles of relationship building and partnership. And I think in our research, we have really tried to do a lot to elevate and value and really prioritize the voice and expertise of community partners in our selection of the evidence-based intervention and how we frame the research and what we're examining and how we're examining it. And I think it's critical that as we're approaching community engaged research and implementation science, we're really thinking about this in a way that's bidirectional. We're thinking about the benefits of the research, but that there are mutual benefits for community members as well. And I think that's essential to building trust and the trustworthiness of the partnership. I think our example of how we have given back the data and been really transparent about that process is something that for us has helped enhance that trust. But there's lots of ways that we can think about doing that, whether it's sharing of resources, sharing of leadership, sharing of decision making. So there's a lot of ways that can show up in our implementation science grants. Okay, I'm going to skip all this. Okay, a couple big picture things as well as we're thinking about community and patient perspectives in implementation science. As I mentioned, often our context and our community unit is multi-level, right? So we have to think about at each level of engagement, who is and isn't at the table as we're making decisions about implementation and as we're planning implementation. And for us, again, that has meant involving the national leadership of the community organization, the site-specific program directors, and then also the implementers who are community members. So for us, we really have tried to engage the full spectrum. both in our research and our data collection, but also in our decision making, right? So the community leaders are co-investigators on our grant, they're involved in our publication, and they have a lot of say in what the distribution of resources look like in terms of being able to support site participation and community participation. So I think these are all important questions that have to be negotiated when we're doing community engaged research and are critical in implementation science. I didn't have time today to go into too much detail about, the different types of methods that we used. Again, we often use CBPR, but there's lots of different methods in terms of human-centered design, boot camp translation, advisory committees, focus groups. There's lots of different methods we can use for community engagement. This is a paper we published where we did a systematic review of really who is engaged in community engagement efforts in behavioral medicine and how are they engaged. And I think this is kind of where the science needs to go. We need to better understand what are the best ways to engage partners, which ones are effective and acceptable. And I think the science is still evolving in this area, but just an example of some of the types of approaches and levels of engagement that can occur. I think increasingly too, there's real interest in not just the process of community engagement, but also understanding how does that then track in terms of improved outcomes. So I've talked about it today in the context of sustainability as an outcome, but Shobha Ramanathan and colleagues have done some really nice work thinking through other possible outcomes to track in order to understand how successful community engagement has been, right? Everything from, has there been improved community health and well-being? Has there been improved dissemination of knowledge? Has there been increased capacity for research in community settings? Has there been positive shifts in social capital? So there's some nice markers that might be relevant as well for some of the work that you're doing. And finally, as we bring it back to this intersection of community engagement and sustainability and how I'm thinking about it in my own work and the opportunities for the field, I think there's three core areas where I think community engagement and sustainability work is really critical. One is as we're thinking about our frameworks, as we're doing work, whether it's implementation frameworks or sustainability frameworks, we have to step back and think about how much our frameworks reflect the communities we're partnering with. And there may be opportunities, just like I showed you with our framework, about how we can shape those frameworks with community input and refine them and learn from them over time. So there's some nice work in the field that's kind of identified some community engagement in our implementation science frameworks, but I think we have a lot of work to do still in that area. Juliette Iwellenmore has a really nice framework that she calls the PLAN framework that really is about planning for sustainability with community partners from the beginning. So I won't go into that in detail, but here is the article if you're interested in that. It's a really nice process framework to think about this intersection of community partnership and planning for implementation to kind of lay the foundation for sustainability. And finally, as we're thinking about our sustainability strategies or our implementation strategies, what we're actually, the how of how we're actually getting our interventions embedded in community and public health and clinical settings. Again, I think there's real promise in involving community partners in the selection of those in terms of knowing what might work. And also thinking about ones that build further capacity in those settings so that we're not in this place where once the implementation supports are gone, we're not able to implement or sustain. So thinking about capacity building as a critical part of those strategies. Okay. There are lots and lots of opportunities, I think, to do work in this area. I've highlighted some of the work we've done in the field and thinking about sustainability and this intersection with community engagement. But I encourage you to really help advance some of the empirical work in this area because I think that's where we have some of the biggest gaps. Okay, I want to thank community partners from the National Witness Project. I want to thank my colleagues at Columbia and also my colleagues in Australia who I've had the honor of partnering with on a global sustainability forum to help advance some of these issues. So thank you.
Thank you so much, Dr. Shelton. This was an amazing, amazing talk. I loved it. And the overview of your whole research program and, really the history of how you came to looked at different questions, and I think it was really, really well put together. So I think have so many questions. So we have some time for questions.
Yeah. Should I stop sharing so that?
Yes. I think you can stop sharing. So I'm going to ask maybe one or two first questions. If you have any questions, please put them in the Q&A section, and I'll get to them in order. So I guess one of the first questions I have would be a common theme throughout your talk was around building trust, right? It came back multiple times, and I completely agree that it's central, especially given this environment. That there's some issues around different types of interventions and public health interventions for sure. So I wondered if you could talk a bit more about, in your experience, how to build trust and some strategies maybe that you've experienced with individually or in the context of your research that were effective or not so effective sometimes, or that would be, I think, a good starting point.
Yeah, I think there's been a couple things. One, as I mentioned, I think a critical part for me as a researcher was spending time in the settings at the sites. That was kind of number one. I mean, I did that for a couple of years. I was very much on the road because I realized I could not it wasn't the kind of thing where, especially with this group, working with a group that was new and that was national. I had the kind of like the warm handoff of the original developer of the program, which was essential. That was essential. Like I couldn't have even opened the door without that. But then I really had to kind of prove myself in terms of then being trustworthy. So I think that's where the relationship building happened. And I think part of that was spending time in those sites, building those relationships. That it makes such a difference to be able to like then send an email follow up or move something forward once you have that interaction where you've spent time, you've had meals together, you've been there, they know who you are. When someone mentions your name, they have a face to go with it. And especially because some of these women, they tend to be, I think the average age is in their 50s, so for them, I think that in-person time was essential, and having that kind of trust and credibility from the national leadership together with having that face-to-face time was essential. I think the other thing was, it can't always be about building the trust. Can't always be about the research. We were very lucky to get that first research grant funded. That was very exciting. But then we had a 5-year gap where we didn't have any research funding to support that partnership. But we didn't stop the partnership. So for me, during that time, it was really essential to then think about what resources do I have, or what expertise, can I give a training in something? Can I refer this partnership to another group who's doing research who might have resources? Are there ways that I can still support capacity building, or, just any resources I could bring to bear was critical during that time, so that it was clear that, it was about impacting their work and impacting their ability to deliver the programs beyond just the research grants and publications. So that part was really critical, I think, that we stuck it out over those 5 years. We kept doing work together until, we were very lucky then to have some funding to support that, but we were going to partner one way or another. And then I think the other part has really been the transparency piece, right? So I've learned a lot with that piece through, not always doing it perfectly from the beginning in terms of understanding, the transparency in terms of like, it's tough to say like, oh, we have this grant due next week, let's put it in, and not, that can't happen, right? So really having to be thoughtful about the process, the communication, the engagement, what do they want that to look like? What is feasible for them? What monetarily, what makes sense to support that? Just even things that seem little things like gift cards, and where that's coming from, how, things that just seem like small aspects of the research aren't, they're all of that, like the attention to all those small details and the transparency and communication and ability to kind of adapt to their needs and listen to them. has been critical. And then finally giving the data back. Like, honestly, we haven't published much of that data from the American Cancer Society, but we have given them every year of that data back. We hired someone who did full-time site reports for them. So they have tailored 100-page site reports with all the data. They have, at their fingertips. We presented it. We gave it in every format they wanted because that was the thing that was most important to them at the time. So we prioritized that. So again, just being a good partner through kind of funded and funded and unfunded times, and being transparent is really critical.
Fantastic. These are fabulous takeaways. So helpful. So we have a first question from Professor Sylvie Lambert. She's asking, in some settings where implementation efforts have struggled, clinicians have noted that if patients ask for it, it will happen. From your perspective, how do you view the role of patient family-driven demand, implications, engagement in driving innovations and how they're prioritized and selected, basically?
Yeah, I think that's critical. I think that's a really important lever. I think often it has to be multiple things that align, right? So it may be about, you have to have the leadership buy-in in that setting. There may be costs that are implicated, but often you see the patient as a really important driver of whether or not something is delivered or not. I can give the example that we have right now. We're doing a de-implementation trial, which is a whole other set of challenges. So we have a study where we are trying to reduce mammography overscreening for women 75 and older. So most women 70, they might be in their mid 90s and they're still getting, in many cases, annual mammograms. And there's some harms and some considerations with that. So we have been doing a multi-level health system, clinician, and patient level study to understand the drivers of why that happens and to really target strategies. And we're finding that it's really hard to de-implement something that patients want. And in many cases, even if we have, right now we've been doing some strategies with provider education and, providers understanding how to turn off in the EHR system these alerts that activate them to do it. And at the system level, changing maybe some of the letters where some of the language changes around the recommendation from radiology or from primary care. So even if we get that aligned, a woman can still bypass their provider and get mammography screening if they want, right? So often we do see the provider as an advocate or a driver, and we see also, cancer survivors are often big, you see the power of kind of advocacy sometimes with these organizations and women not feeling like they want something, the personal story of that, right? That they don't want something taken away. So I think that can be a big driver, and especially if it aligns with what's happening, in the organizational level. And so that's kind of an example of where we've seen that.
Fantastic. We have a comment from Professor Kimani Daniel saying, this is a comment, not a question. This was a brilliant presentation. I appreciated the insights about engaging in community, particularly around co-creation, maintaining relationships. I love your authentic presence. Very helpful to our continued work in engaging Black communities in our current project. So thank you.
Thank
you. A question from Sonia Castiglione. So I'm curious about your take on the 3% of studies funded with a focus on sustainability. What do you attribute this to? What are the challenges in conducting research focused on sustainability or being successfully funded to do sustainability studies in healthcare?
Yes, great question. Yeah, so what they found is that only 3% of studies had focused solely on sustainability. So what often happens is that people will do an implementation study and they say, oh, we'll look at maintenance or we'll look at sustainability. But often what happens is they run out of time, maybe things took longer in the implementation phase, and they often don't get to it. And if they get to it, it's often the maintenance phase, which we know is usually typically more like 6 months. So what they found is that methodologically and just in terms of feasibility in the context of a lot of these implementation trials, even with the best intentions, people just don't get to it because they run out of time, or they don't have enough time to look at 1 year, 2 year, 3 year plus in the context of the length of our research studies. So again, we've made the case that we should really separate out, when possible, studies that are focused on the implementation phase versus the sustainability phase because of this challenge. And we found that while a lot of the factors that matter for implementation also matter for sustainability, so again, things like champions, organizational infrastructure, attrition, a lot of those, there are some specific ones that matter in particular for sustainability that might be different, right? Things like leadership turnover, things like alignment with policy over time that changes, things like staff attrition. So there may be additional considerations for sustainability that we need to think about. What I always suggest, and what I have done in my work, is I think it can be really nice to start with a program that already has gone through. Maybe there's some trials where they've already done the implementation period. Maybe maybe it was a 5-year grant and they tested implementation strategies. Then maybe there's the chance to build in a new study that starts off then to understand, maybe it's looking at patterns in sustainability over time or predictors of sustainability, or it tests sustainability strategies to understand what's needed to sustain it beyond that, whatever it was, 3-4 year period. So that's often where I have come in, is in those later phases where there is that transition from the implementation to the sustainability. And you're not starting from the very beginning of that effort necessarily, but you're coming in at a period where it's already been in place for some years and some time to understand that. So that's the approach that I've taken. So it requires some partnership often. I think so many implementation science studies require these large scale partnerships, but I think especially with the sustainability, if you're trying to get a grant in that area, it requires either partnering with existing evidence-based interventions that are on the ground but are having challenges with sustainability, or partnering with researchers who are doing implementation studies, and there's an opportunity to embed some sustainability there moving forward.
Excellent, thank you.
Mm-hmm.
Dr. Yiking Lu is saying, great talk. Was wondering, what is your view around how implementation science frameworks for sustainability should be adapted to ensure long-term, high-fidelity delivery of molecularly guided precision oncology and routine nursing practice? That's a very specific
Oh, wow.
question.
I'm gonna have to look at that one. Let's see. I'm definitely not an expert on molecularly guided precision oncology, but I would say, in my view, there's real value in focusing on, if you want to look at sustainability, there's a real value in looking at sustainability specific frameworks. And I would recommend, what we have done is we did a review in the annual review of public health in 2018, where we reviewed about 300 articles, empirical articles on sustainability. And we identified what were some of the common factors across different levels, no matter the setting or population or context. And we have found that people can use that as a starting point for thinking about sustainability, and then doing some qualitative work in the setting on their own end to then refine that a bit and operationalize it. So we have, in the Practical Implementation Science textbook, we have a qualitative interview guide that maps onto that framework that people can use to start planning for sustainability in their specific setting and understanding context. So that's what I would recommend, is as a starting place. I don't know of any specific work that's happening there in precision oncology. I know Megan Roberts and colleagues are doing a lot of work on precision science in general with implementation science. They have a whole training program that's devoted to that, where they're thinking about genetic testing, not specific to cancer, but there may be some work there as well, out of UNC that's relevant. But that's a good future direction, because I don't think anyone's done anything there.
Sounds good. So if any of you have any additional questions, last call for questions. I'm going to ask one of my own again.
Yeah.
If that's fine. So at one point, I think at the start of your talk, you talked about understanding the capacity and potential for an intervention to be like the sustainability potential,
Yep.
let's say.
Yep.
Could you speak a bit more about that piece and kind of, I would be quite interested about hearing more.
Yeah, yeah, and I think that maps on a lot to that qualitative guide, which I'm happy to share. Um, I think that gets at a couple different things. One is, what is the intervention and its characteristics, right, in terms of capacity to sustain? And that's where you have to really think about and engage with the population and setting in terms of the fit with that setting and its possible integration. So everything from, how complex is this intervention, right? Does it align with the setting? Is their organizational readiness or capacity to integrate into the clinical workflow, right? Are there costs associated with it? Or, what's kind of the case in terms of the business value or the return on investment? One thing we know is that more flexible interventions are more likely to be sustained because they do provide that opportunity for some adaptation, selection, and ownership. And so that's another characteristic. If you have one that's very complex, rigid, costly, that might be more challenging. So I think that's what we're talking about in terms of that capacity piece, is both the capacity specific to that evidence-based intervention, and kind of with respect to those characteristics, and then that kind of fit of that with the setting and its capacity. So in that guide, we have some questions that can help kind of unpack that and think about, everything from, integration to staffing, all those things that would need to be in place for a site to have the capacity to implement. The other thing is the PSAT and the CSAT, the sustaintool.org, the website that Doug Luke and colleagues have developed. That is such a fabulous tool. We have used it both as a measure to look at predictors of sustainability, as well as that's all the data that we provided back to the site. So it's a really nice practical tool where sites can fill it out. It can be anonymous, and then they can look at it themselves, right, in terms of areas where they feel like they're strong or need more support. So I think that can also highlight areas where there's more capacity for sustainability that might need to be built. So that's a great both research tool and practical tool. And the practical implementation, if you email me or if you reach out to me, or I can also just send it with my slides. I can send that interview guide that we have for the qualitative guide that maps onto the practical implementation science. I don't know if that textbook is available online, but I think it's just available by purchase. So I can just email it to you.
Fantastic. Okay, so maybe one last question, if you have time still. So I'm curious about how you think about essentially the links between you mentioned that an intervention that is more flexible would be more likely to be sustained, right, over the longer term. So how do you think about sustainability with fidelity and adaptation? And like, I guess those relationships and in the context of your own experience and what you've seen.
Yes, that is such a messy area. Like when I first started getting into this work, when I was thinking about sustainability and how to measure it, I think the field was kind of at the place where it was like, sustainability is continued delivery with fidelity, at all costs of all components of the evidence-based intervention. And I think the field has moved away from that. With kind of this recognition, David Chambers introduced the dynamic sustainability framework. And I think, again, that really introduced this concept that sustainability is not like this static end goal, and that sustainability actually often requires adaptation. So again, I think the science there is trickier because it really depends on the type of adaptation we're talking about. And people often talk about fidelity consistent and fidelity inconsistent, or they talk about form and function. A practical example, I think, is when we think about our evidence-based intervention that we're tracking, we might have adaptations, because again, the guidelines change. So what the women are delivering, different components of it in terms of the scientific best practices, that actually should, right? That would be a good thing. That would be fidelity consistent ideally, because the guidelines have changed, the program needs to adapt, right? But I think that to me is different than just removing a component of the program. If all of a sudden they said, well, we're just going to remove the testimonial piece because we don't have time to do that anymore, right? That's a component of the program that we know has been really effective and important. So I think it's complicated because it's not just about adapt or not. It's not about fidelity, yes or no. It's more about understanding changing science, understanding changing needs, right? In some cases, you might keep fidelity to the program in terms of those components. You might adapt to the science, and you might adapt to new community needs. So we learned that not only breast and cervical cancer are important, but also colorectal cancer or addressing, food insecurity, right? So there's another adaptation while still having delivery of the original program. So I think that's complex and nuanced, and it's really complex in terms of the measurement, because I think it requires that over time you're understanding how the program is delivered and sustained, what it looks like, but also why it's being changed, and then what's the impact are you still having those benefits, right? So it's complicated to say the least. But I am a believer that planned adaptations in response to changing science and changing community needs are critical to being able to sustain the program. And that if we're not responding to those, then we're going to have challenges, I think, to sustainability. So I think it's a bit of an art and science there with that.
Fabulous. Thank you so much for your time today, Dr. Shelton. This was an amazing discussion and talk, and it's going to be recorded and posted on YouTube so people can watch it back for those that were not able to attend today. And for the resources as well, we can follow up with the specific resources. And yes, thank you everyone for attending today. The next session is going to be with Ian Graham in October. So we're going to be delving a bit more into co-production and different approaches to co-production, and it'll be quite interesting as well. So thank you so much, Dr. Shelton, and thank you everyone for being there today.
Thanks so much. Thanks again.